Good afternoon, everyone, and welcome. I'm Liz Krueger. I might or might not be your state senator, but if you live here in New York State and you are becoming eligible for Medicare or need to change your Medicare plan, because this is the time of the year where you have that option, you are in the right place. I'd like to welcome program participants who are viewing on Zoom and or Facebook, or who are calling into this town hall. The topic today is Medicare Parts A, B, C, and D, changes you can make to your coverage. And again, for some of you, this might be the first time you're signing up for Medicare, and it's more confusing than we wish it was. As always, we have closed captioning for today's event, and as a viewer, you have to activate closed captioning to view the text. If you're in Zoom, click on live transcript in the meeting controls to start viewing closed captioning. And if you're watching on Facebook Live, you will see a setting button in the bottom right-hand corner of the video. Click on CC for closed captioning to activate the process. As always, we are recording this forum, and everyone who RSVP'd will receive an email with links to the event video, an event survey, and the resources that are posted in the chat within a few days, along with the presenter's PowerPoint. So there's a lot of detail when discussing Medicare coverage, and we have a great presenter, but don't worry, you don't have to scribble everything down. You can just listen, think through what you understand, what you don't understand, and know when you get all the materials forwarded to you in a few days, you'll be able to go and review anything that you still had questions about. Now we're going to move to today's event. We do this each year, and I have to tell you, it is so important, and so many people come and watch. I'm always wondering, are people watching over and over again, or is it new people getting on? Whichever is the story, it's great, and we really appreciate that we have an amazing presenter, which I'll talk to you about in just a minute. But again, to remind people, there is an open enrollment period for everyone who is Medicare eligible each year. And it will begin next week on October 15th and continue through December 7th. You may start to be seeing TV commercials about Medicare, ads, mailers encouraging you to sign up for specific types of Medicare coverage or a specific plan. And frankly, making decisions about what Medicare plan to cover or to choose for the best price and the best services based on who you are can be really confusing, which is why we are so delighted that yet again this year we have Eric Hausman, who is the volunteer outreach manager from the New York City Department for the Aging's Health Insurance Information and Counseling Program, which we call HIICAP. It's quite a mouthful. But Eric is the expert on all things Medicare and has an enthusiastic following among my constituents. I feel like, he's like our TV star. He's in our webinar every year. Eric will be providing Medicare updates for 2026, including information about changes in premium rates and deductibles for Parts A and B, changes to Part D, your prescription drug coverage, very important for so many of us as we get older. And additionally, you will learn about Medicare Advantage and supplemental plans, programs that can help defray Medicare costs, including drug prescription costs. You should be aware that federal cuts to Medicare may impact the cost and scope of your coverage for next year and beyond. That is why we're having a roundtable discussion next Tuesday to address the impacts of cuts to Medicare and Medicaid on New Yorkers. But for now, we don't have an enormous amount of detail about what could possibly be happening, because the federal government seems to change the rules of the road almost every day on everything lately. A lot of useful information will be shared during this town hall. And again, please do not worry if you miss something. You'll be able to watch the event video again in a few days and review anything that we go over today. We have received many questions already, and I am certain we will get additional questions submitted during the event. Eric will answer as many general questions as time allows. We will not be able to answer specific questions about your individual coverage. For specific questions, or if you've submitted a general question that we were unable to get to today, please call the Health Insurance Information and Counseling and Assistance Program known as HIICAP. The telephone number is 212-602-4180. The number and the website is going to be listed in chat. And the people who answer those phone calls are also incredibly knowledgeable, and they can go over some more personal details about questions that may only apply to some of you, but certainly not everyone. This town hall is a general session on Medicare, particularly designed for individuals who will turn 65 soon or are seeking to make changes in their current Medicare coverage during that open enrollment period, which ends on December 7th. And now I would just like to introduce Eric Hausman, who is going to go through a detailed presentation. Then we will come back, I'll come back, and we'll start a Q&A portion of the event. Again, if you submitted questions that we don't get to this afternoon, you should reach out to HIICAP, and the HIICAP telephone number once more, 212-602-4180. And with that, I would like to turn this over to Eric Hauser. Good afternoon, Eric.
Thank you, Senator Krueger. So I'm just going to bring up the slideshow. And here we go. So Senator Krueger introduced our program, HIICAP, where we have volunteer counselors that are able to help you and others in New York City with questions on Medicare and related health insurance. So today I'm going to provide an overview of Medicare and choices in Medicare, including some updates for 2026. So as you know, Medicare is a federal health insurance program, and mostly it's for people that are age 65 and over. And whenever we meet people that are turning 65, and that's all the time nowadays, my first question to them is always, are you collecting Social Security? Because people can start collecting Social Security retirement as early as 62 or as late as age 70. If you're collecting Social Security prior to age 65, you're going to be automatically enrolled in Medicare. But for those not collecting Social Security prior to 65, it's up to you to enroll in one of the Medicare enrollment periods. The first enrollment period is called the initial enrollment period. This is when people are first eligible for Medicare. It's a 7-month period. For most people, it's the 7 months surrounding the month you turn 65. So that means the 3 months prior to the month you turn 65, the month of, the 3 months after that. If you enroll in Medicare in any of the 3 months prior to the month you turn 65, Medicare starts the first of the month you turn 65. If you enroll in Medicare Part B medical insurance the month you turn 65, or one of the next 3 months, Part B starts the first of the next month. Now, some people, when they turn 65, they're still covered under their own or their spouse's, not domestic partner, but their own or their spouse's active current employment, not retiree plan, not COBRA, but active current employment. If that's the case, you can actually delay enrollment in Medicare Part B and enroll later using what they call the special enrollment period. So for instance, maybe you're turning 65, but you're still covered under your spouse who's working for the city of New York. You can delay Part B, and then a couple of years later, when your spouse is ready to retire, sign up for Part B then using the special enrollment period without having to wait and without paying a penalty. That's very common for people that are still working who are covered under a spouse who's still working for a large employer when they become Medicare eligible at 65. Now, for those that don't enroll in their initial enrollment period, who don't qualify or maybe miss the special enrollment period and then realize later they need Part B, they make them wait till an annual period to sign up. It's called the general enrollment period. Every year, January through March. If you sign up for Part B then, Part B starts the next month, but you may be subject to a penalty. The penalty for late enrollment in Part B is 10% of that year's standard premium for every full 12 months you delay. And that 10, 20, 30, 40, 50, 100% or more penalty, it's not a one-time penalty. You pay that for the rest of your life. So I just want to stress to everybody, the only people that can delay Part B at 65 and sign up later without having to wait and without being subject to the penalty are the people that are covered at 65 under their own or their spouse's active current employment. Now, once you do enroll in Medicare, they send you this red, white, and blue Medicare card in the mail. And on the Medicare card, it shows you the two parts of Medicare. Medicare Part A is your hospital insurance, covers you if you ever need to be admitted to the hospital or a skilled nursing facility. Medicare Part B is your medical insurance, covers you mostly for doctor services, outpatient services of the hospital. So let's talk in the next section about costs in Medicare Part A and Part B. Starting with the Medicare Part B premium. Now this year, the standard Part B premium is $185 a month. Some people pay a higher premium because they have a higher income, but for most people, it's the $185. You may have seen in the news about the premium going up next year to $206.50. The $206.50 is actually an estimate of the premium for next year based on the Medicare, what they call trustees report that comes out in the spring of each year or summer. The premium and the other Part A and Part B amounts have not been announced yet for next year. They should be announced later this month. So in the meantime, we're just providing the estimates. So again, besides a monthly premium for Part B, there's an annual deductible. This year, it's $257. So that means the first $257 in covered medical expenses this year is your responsibility. Once you meet the deductible for most services, Medicare pays 80%, you pay the other 20%, the Medicare coinsurance. That's how it works for Medicare Part B for doctor services. For Medicare Part A, it's completely different. Although most everyone gets Part A for free, for no premium, there's a large deductible if you need to be admitted to the hospital. So this year, for hospital admission of up to 60 days, Medicare Part A pays everything but the deductible. If you're in the hospital beyond 60 days, for the 61st through the 90th day in the hospital, you're responsible for a daily copayment. If you're in the hospital beyond 90 days, Medicare allows an additional 60, what they call lifetime reserve days, which you can use once during the lifetime of your Medicare coverage in any combination. But once you've used them, that's it. They're non-renewable. If you're discharged from the hospital to a skilled nursing facility for rehab care, Medicare pays the first 20 days there in full. The next 80 days, you're responsible for a daily copayment. Now, these Part A benefits, they're not a calendar year benefit like Part B. Part B is fairly simple. You know, you got one deductible, $257. Once you've met it, that's it. You're done for the year. But the Part A deductible, somebody may have to meet that more than once in the same calendar year, because it's once per what they call a benefit period. A benefit period begins the day you're admitted to the hospital, and it ends when you've been out of the hospital and out of the skilled nursing facility for a period of at least 60 consecutive days, at which point your benefits renew. They start again. So for instance, you could be admitted to the hospital tomorrow for 5 days. Medicare is going to pay everything but the deductible. But what if a couple of weeks later you need to be readmitted to the hospital or a different hospital? Same condition, different condition, doesn't matter. Less than 60 days have gone by since you were discharged. You're still in the same benefit period. You just pick up where you left off. At day number 6 of your first 60 days of coverage, you don't have to meet a new deductible. But what about instead of being readmitted a couple of weeks later, what if you're readmitted 3, 4, 5 months later? Could be the same calendar year, but now it's a new benefit period. More than 60 days have gone by since your discharge. Your benefits renew, they start again. You're back to day number 1 of your first 60 days of coverage, and you have to meet a new deductible. So I hope this slide will help to point out the importance of people having other insurance besides Medicare. Because for those that have Medicare only, you could see you could wind up paying a lot out of pocket, especially for hospitalization. Now, for those that are in original traditional Medicare that we're speaking about so far today, Medicare has provided coverage for telehealth services provided via telehealth as opposed to in person. Prior to the public health emergency, this was very, very limited coverage, and primarily for people that lived in rural areas. But during the public health emergency, it was greatly expanded, and Medicare was covering many services via telehealth for people to access from their home. But as of October 1st this year, most telehealth services are no longer covered under original Medicare, except for certain mental health services. But otherwise, telehealth, it was previously this expansion of telehealth coverage was going to end the end of March. The government extended it through the end of September. And it's possible that when the government shutdown ends, that Medicare coverage for telehealth can again be extended. It's also possible that the coverage can be effective retroactive to October 1st, but we don't know that yet. So at this point, okay, that coverage ended as of the end of September, again, with some exceptions for mental health under original Medicare. Now, for those that have original traditional Medicare, some of you may have retiree health insurance from your own or your spouse's former employer that fills in the gaps in original traditional Medicare that I spoke about so far today, the gaps in Part A and Part B. For those that don't have retiree coverage, some of you may have very limited income and resources, and you could qualify for Medicaid in addition to Medicare, where so long as your providers accept both programs, you don't pay anything out of pocket for covered doctor and hospital services. But nowadays, most people don't have retiree health insurance. Most people, their income's too high for Medicaid. So what do? They can purchase a private Medigap, a Medicare supplement plan. You may have seen them advertised on TV from AARP. Medigap plans are identified by letter. There are 10 standard plans ranging from plan letter A to plan letter N as in Nancy. All of these Medigap plans cover certain things. They all cover days 61 through 90 in the hospital. They all cover the 60 lifetime reserve days. Most of them pay the Part A deductible. Most of them pay the entire 20% Part B coinsurance. And then other benefits vary from plan to plan. But here's the 2 most important things to know about Medigap insurance. One is that the benefits are standard. So different companies sell these plans, and they charge different amounts. But as long as it's the same letter plan, doesn't matter what they're charging. It's exactly the same coverage, exactly the same. So it's well worth your while to shop around for the best deal on a Medigap plan. The other thing that's really important to know in New York State, unlike most states, we have continuous open enrollment for Medigap insurance. So that means as long as you're on original Medicare and you got A and B, you can sign up for a Medigap plan anytime. And if you have a Medigap plan already, you can switch to another Medigap plan at any time. You cannot be denied Medigap insurance because of your age or because of your health, not in New York State. What you might run into, though, is a waiting period for pre-existing conditions of up to 6 months. So that means they'll sell you the plan, but they may not cover a service related to a condition you had prior to buying the policy for up to that first 6 months. However, again, most people we meet that buy a Medigap plan don't have to worry about pre-existing conditions because they've had some sort of prior credible coverage that can count towards that. And that could be most anything. It could be another Medigap plan. It could be a Medicare Advantage plan we'll talk about next. Employer plan, retiree plan, COBRA, plan through the marketplace. Okay? So as long as there's no break in coverage or a short break of less than 63 days from when the prior insurance ends and the Medigap plan begins, they credit the time with the prior coverage towards meeting the waiting period. Now, here's the thing to know for January coming up. Most every Medigap insurer is seeking rate increases, which, if approved by the state, would be effective January 2026. If it's going to be approved, the insurer has to give you at least 60 days notice. So that means they need to notify you by the end of this month about any changes. But the good thing is, if your insurer is raising their rates and come January, another insurer has the same plan for less money, you can just move to that insurer and have the same coverage from a different company. And although the company might have waiting period for pre-existing conditions, they will credit the time that you had the Medigap plan from the first insurer towards meeting the Medigap waiting period with the new insurer. So far today, I spoke about one way to get Medicare, original traditional Medicare, which can come along with supplemental insurance through a former employer, through Medicaid, through a private Medigap plan. This is the other way to get Medicare, to join a Medicare Advantage plan, Part C of Medicare, some may call it. And these are private plans that are contracted with Medicare to provide all of your benefits through a network of doctors and hospitals, through doctors and hospitals that participate, that take that plan. Most everybody's eligible to join. You just have to have Part A and Part B of Medicare, and you have to live in the service area of the plan. That's it. But unlike Medigap insurance, which we said, if you're on original Medicare and you live in New York State, you can buy a plan at any time or switch from one insurer to another at any time. The Medicare Advantage, for most people, there's only certain times of the year that you're able to sign up or switch. So first of all, you can enroll in a Medicare Advantage plan when you're first eligible for Medicare and enrolled in Part A and Part B. If you don't, or you did and now you want to switch, most people have to wait till the annual election period, which is starting next week, October 15th, and runs through December 7th. If you enroll then, your new plan starts January 1. If you realize in January that was a mistake, fortunately, there's another enrollment period, the Medicare Advantage open enrollment period, where anybody that's on a Medicare Advantage plan at the beginning of the year has between January and March to switch to either another Advantage plan or original traditional Medicare. One time, January to March, to start the first of the next month. And it's important to remember, if you join a Medicare Advantage plan, you're not giving up your Medicare benefits. These private plans are required to cover whatever Medicare covers, plus, as an incentive to join, they will cover to limited extent some services Medicare doesn't pay for. So they typically provide limited coverage towards dental, towards a vision, eyeglasses, towards a hearing aid. They might pay for a gym membership for you, all things not covered by Medicare. But what I think is the biggest incentive, especially in our area, is that plans may be available for as low as zero premium. I bet you've seen them advertised. Zero premium. You're still going to pay that Part B premium, the $185 or whatever you're paying for Part B. They're saying zero additional premium. And that could be a powerful incentive, I would say, for somebody that does not have retiree health insurance, that does not have Medicaid, that cannot afford or doesn't want to pay $300 or more a month for the typical Medigap plan. You might want to join a zero premium Medicare Advantage plan instead. But even if the plan has no premium, that doesn't mean the plan's not going to cost you anything. It's going to cost you on the other end when you access care, usually in the form of a copayment. So many plans have no copayments for primary care doctors, but they all have copayments for specialists. Some are $20 or $25, some are twice as much. If you're admitted to the hospital, most every plan has a daily copayment up to a maximum number of days, $200, $300, $400, $500 or more dollars per day for the first 3, 4, 5, 6 days in the hospital. If you need mental health or physical therapy, plans can have a $20 copayment or it could be twice as much. So the bottom line with the Medicare Advantage plans is not 100% coverage for most services under most plans. And you're going to pay something at the end of the day when you access care, co-payment or co-insurance. But in fairness to the plans, it's not an unlimited amount that you could be responsible for. All Medicare Advantage plans have a maximum out-of-pocket limit, abbreviated MOOP, M-O-O-P, for all Part A and Part B for hospital and medical covered services. Next year, slightly lower than this year, could be as high as $92.50 in network with your plan. So if you have a plan next year with a $92.50 limit, and it's $400 a day when you're admitted to the hospital for the first 5 days, that $2,000 out of your pocket goes towards the limit. If it's $45 every time you see the specialist, that goes towards the limit. If you reach the limit, most people won't, but if you do, 100% coverage for the rest of the year for all Part A and Part B covered services. This is the highest limit any plan can have next year. Many plans have that limit, but some plans have lower limits, and that's something you may want to compare when you're looking at different Advantage plans. You should also compare the type of plan. In New York City, historically, it's been mostly HMO plans. With an HMO plan, unless it's an emergency, you're limited to doctors and hospitals that participate, that accept the plan. If you go outside the network, you're going to wind up paying the cost out of pocket. But over the years, more and more companies are offering PPO, Preferred Provider Organization plans. Like the HMO, they have a network of providers. And if you use their providers, their doctors and hospitals, you'll pay whatever copayment the plan has. The big difference with the PPO, you can go outside of their network to doctors and hospitals that take Medicare. They just don't accept the plan. And you might pay more out of pocket, sometimes substantially more. You might even have to pay up front and then seek reimbursement from the plan. But for that reason, the PPO gives you more choice, more flexibility than does the stricter HMO plan. And then for folks that have both Medicare and Medicaid, who we refer to as dual eligible Medicare beneficiaries, they have a special type of Medicare Advantage plan just for you, called a Special Needs Plan, SNP. Besides first of all, the doctors that are in network all take both Medicare and Medicaid. So all in special needs plans, as long as the services are covered, 100% coverage. And in addition to the extras we talked about, many of the special needs plans provide a significant over-the-counter benefit. You may see it advertised, OTC, where they give you a certain amount of money per month or per calendar quarter that you can use for non-prescription drugs, like over-the-counter medications or vitamins. You might be able to use it for toiletries. You might be able to use it to pay your utilities, for food. You might have to have certain chronic conditions to have some of these additional flexibilities, but it is an additional benefit. But when people join a Medicare Advantage plan, they shouldn't join just for the OTC benefit or the extras. Because when you join a Medicare Advantage plan, you're putting away your red, white, and blue Medicare card, and you're agreeing to get all of your Medicare benefits through this plan's network of doctors and hospitals. Now, whichever way you decide to go, whether it's original Medicare or it's a Medicare Advantage plan, you're entitled to Medicare Part D. Part D is the prescription drug coverage. If you're in a Medicare Advantage plan, Part D is easy. It's included with the plan. So if you're going to go with Health First Medicare Advantage plan for next year, you get all your Medicare benefits from Health First. Part A hospital, Part B medical, and Part D drug. If instead you're on original traditional Medicare, we have 12 this year, standalone, separate Part D plans to choose from. Next year, it'll be down to 10 in New York State. These 10 plans each have their own formulary, their own list of covered drugs. So not all 10 necessarily cover all your drugs. And they got their own network of pharmacies. So the pharmacy you like, maybe they don't take all 10 plans. How do you compare so many plans? you can either go to the Medicare.gov website, you can call 1-800-MEDICARE 24/7, or if you want local assistance, call us at the HIICAP program. And we'll compare plans. We can do that now for 2026. And if there's a better plan for you for next year, time to sign up. Again, October 15th to December 7th to start January 1. Now, what do these plans cost? Well, first of all, they have a monthly premium, and that really varies. This year, there's a plan that costs less than $40 a month, but other plans cost more than $100 a month. In addition to a monthly premium, they have an annual deductible. Next year, it could be as high as $615. Many plans next year have a $615 deductible. Some have a lower deductible. A few might even have zero deductible. Once you meet the deductible, people usually pay a fixed copayment, a set dollar amount at the pharmacy, until they reach the out-of-pocket cap. This was the biggest change to Medicare that happened for this year, 2025. For the first time, Medicare had an out-of-pocket limit. This year it's $2,000. Next year it'll go up to $2,100. So what that means is that not including your monthly premium, but including what you pay at the pharmacy, deductible, copay, coinsurance, if you reach $2,000 in out-of-pocket cost, again, $2,100 for next year, you will have 100% coverage for the remainder of the year for all Part D covered drugs. Connected to that out-of-pocket limit is this Medicare prescription payment plan, where they allow you to sign up. You can sign up at any time with your plan. And if you do, you'll pay nothing at the pharmacy for your covered drugs. Instead, the Part D plan will take that $2,100 and spread it out over monthly payments over the course of the year. So your plan will bill you the portion of the $2,100. So that could be very helpful for somebody that has really high Part D covered costs, right? Where ordinarily next year, at the beginning of the year, they'd have to pay $2,100 out of pocket in the first month or 2 or 3. Not necessary. You can sign up for this MPPP and spread out. It's still the same $2,100, but easier to finance over 12 months, especially when you don't have to lay out money up front, than over a couple of months at the beginning of the year. So just to recap, for people that don't have retiree coverage and who don't have Medicaid, here are your two choices. And let's talk about advantages and disadvantages of each. You can either be on original Medicare with a Medigap plan, or you could be on a Medicare Advantage plan. It's one or the other. Why would you choose original Medicare? Choice of providers. You can go to any hospital across the country. They all take Medicare. And most, but not all, doctors. And depending on the Medigap plan, it could be pretty complete coverage between the two. What's the downside? High premium for the Medigap plan, plus doesn't cover your drugs. So you need to buy a separate Part D plan, one of those 10 for next year, for another premium. So you see the people on the left here, they pay 3 premiums every month. One for Part B, they're going to pay anyway. A second for the Medigap plan, a third for the Part D drug plan. So they pay the most in premiums, but in exchange, the most choice of providers, the most complete coverage. What about the other choice instead, Medicare Advantage? Why would you say choose that? You save on those premiums. You still have to pay the Part B premium, but some plans are as low as no additional premium. And the drug coverage is included. You don't need a separate Part D plan or the Medigap plan. Again, you save on those premiums and you get some additional benefits that Medicare doesn't cover, dental, vision, gym membership. What's the downside? If it's an HMO plan, especially, unless it's an emergency, you're limited to doctors and hospitals that participate. And even if you don't pay a premium, we said you pay on the other end when you access care, copayment or coinsurance, up to a maximum out of pocket for the year. Plus, this is managed care. So they cover your physical therapy and your mental health and your planned surgery, but you may need to get pre-approval, prior authorization, before those services will be covered. So for some people, it makes more sense to have original Medicare with the Medigap plan. Other people do very well with the Medicare Advantage plan. and that's the choice for all people with Medicare to make. So in this section, I just want to talk to you a little bit about programs that help with the Medicare cost, starting with Extra Help, also known as the Low Income Subsidy, LIS. This is a subsidy the government provides to help people with their Part D drug costs. Most people we see get this automatically because they have either Medicare and Medicaid, and or they're on one of the Medicare savings programs I'll talk about, where the state pays their Part B premium. It's not taken out of their Social Security check anymore. If you're not on Medicaid and you're not on a Medicare savings program, but you have limited income and limited resources as well, you won't get this assistance automatically, but you can apply. And the place you'd apply to, Social Security, best done on their website, Social Security or SSA.gov. Here we have the income limits and the resource limits to qualify. If you qualify, the state can pay your Part D plan premium. So you can have a Part D plan for as low as 0 premium, no deductible, and only small co-payments for your drugs, which you also see on this slide. In addition, people with Extra Help have a special enrollment period where they can actually enroll into a new standalone Part D plan, one of those 10 next year, at any time of the year, to be effective the first of the next month. They cannot use that, though, to enroll into a Medicare Advantage plan, only to enroll again into a standalone plan that works with original Medicare. EPIC is from New York State. It's for New York State residents who are 65 and over, who have incomes that are much higher than the Extra Help limits, up to $75,000 for a single, $100,000 for a married couple. EPIC does not work on its own, though. EPIC only works as a supplement to your Medicare Part D plan, and it works with every Part D plan, whether you have your Part D plan through your Medicare Advantage plan, or you have a separate plan with original Medicare, all Part D. Part D pays first, EPIC wraps around and may help reduce what you pay at the pharmacy. EPIC, for most people, it's a free program. So to give you an idea, if you're a single person, you had an income from last year between $20,000 and $75,000, like many people did, you would be in EPIC's deductible plan. You don't have to pay anything for EPIC, but you'll have to meet a deductible on a sliding scale based on your income before EPIC will pay for your drugs. But if you're somebody that has Part D and you have an income, let's say 30, 40, 50, 60, even 70,000, I don't see any reason for you not to sign up for EPIC. Because even if you don't meet the deductible, so what? It doesn't cost you anything. It's free coverage. And you have EPIC in place should your situation change. And unlike most people who can only change their plan this time of year, EPIC members can change their plan one additional time each year outside of the enrollment period, including into or out of a Medicare Advantage plan. So we help a lot of people apply for EPIC, not for the drug coverage at all, but just to be able to change plans without having to wait till the next year. And if you're not an EPIC member already, you can apply anytime. We have paper applications for EPIC, but there's an online application as well, where you can submit that at this link that you see on the slide. Now, in order for EPIC to supplement Medicare Part D, first of all, Part D first has to cover your drugs. But in addition, the drug manufacturer must also participate with the EPIC state rebate program. Most drug manufacturers do, but over time, we've seen some manufacturers withdrawing from the program. So as of the end of September, Bausch Health stopped participating. They produce many drugs, and these are some of the more popular ones, diazepam, Pepcid, and Wellbutrin. Okay. Merck stopped participating with EPIC as of the end of July. They produce Januvia and other medications. GlaxoSmithKline previously stopped participating with EPIC, July of 2023. So again, if people with Part D that have EPIC, Part D is going to cover most of your cost. But in order for Epic to supplement Part D, again, the manufacturer has to be participating. So if you're currently using medications that are manufactured by Bausch Health and you have Epic, you may want to ask your prescribing doctor to see if they could prescribe something else for the condition that's manufactured by a different manufacturer that Epic could potentially supplement Part D to reduce what you pay at the pharmacy. And then most important is the Medicare Savings Program. The Medicare Savings Programs, for people that qualify and apply, the state will actually pay your Part B premium. It'll put that $185 back into your Social Security check. If you ever met people that have Part B and they're not paying a premium, they're already on the Medicare Savings Program. But if not, they may qualify. Qualify for the Medicare Savings Programs. Look at the bottom of this slide, because these income limits went up a couple of years ago for New York State residents. They're now up to $24.46 a month for a single, $32.99 a month for a couple. Couple of other advantages to living in New York State. First of all, like the Epic program, they don't look at your assets or resources, only income to qualify. On top of that, even if your income's too high, you might still qualify. Because if you're paying privately for health insurance, they allow you to deduct your health insurance premium from your income to be eligible. Now, you cannot deduct the Part B premium because this program pays the Part B premium. So they look at your gross Social Security before the premium is deducted. But other premiums you can deduct, most commonly a Medigap premium. So if your income is maybe $2,700 a month as a single person, but you're paying $300 a month for your AARP Medigap plan, you can deduct that $300. Now you're eligible. Sometimes we meet people whose income's only slightly above the limit, $5, $10, $15. For them, it'd be worth it to buy some cheap dental policy or vision policy, whether you need it or not, for $20 or $25 a month. Just paying that $25 a month, now you're saving $185, and I'm sure more next year. And automatically you're getting extra help, which can pay your Part D plan premium, eliminate any deductible, and reduce your copayments to small copayments at the pharmacy. And on top of that, if you have Epic, Epic will take those small extra health copayments and reduce them even further to an even $3 at the pharmacy, $3. So these are the people that do best, the people that qualify and apply for the Medicare Savings Program. We help people apply in person, and we help them recertify at the Department for the Aging, 2 Lafayette Street, by appointment. So I just want to give you a little preview of some things that are changing for 2026. We mentioned that there'll be 10 standalone Part D plans for next year for people in original Medicare to choose from. The Cigna plans are now going to be under the HealthSpring name, and the lowest premium plan currently is the WellCare Value Script, $38.70, increasing to $42.40 next year. But next year, the cheapest plan is actually going to be from Cigna, HealthSpring Assurance RX, which will be $35.70. So for some people that don't use any drugs, that just wanted to take the cheapest plan and chose the WellCare Value Script this year for that reason, you might be thinking about HealthSpring Assurance to save a few dollars next year. And of the 10 plans that are available next year, 2 of them are the benchmark plans. Those are the plans that are available for zero premium for people that get the extra help, including people that have Medicare and Medicaid. This year, we have 3 of those plans. And I want to draw your attention to the SilverScript Choice Plan. This year, that's a benchmark plan. It's $66 a month. Next year, it's going up to $50, $116 a month. It's above the subsidy, and people with extra help that are in that plan, they may be moved to one of the 2 benchmark plans. But if they're not, and they don't choose one of those plans, they could be responsible for the difference above the subsidy, which will be $57 and change. And they might be very surprised to be billed by that next year for SilverScript, where they were paying nothing this year in terms of premium. And then we've been speaking to people that are in a Medicare Advantage plan, but their plan is terminating at the end of the year. They should have received notice by late last week. And these individuals ideally will choose a new plan by December 7th. But if they do not choose a new plan, fortunately, there's a special enrollment period for them. It begins December 8th and runs through the end of February. So they can enroll in a new plan by the end of the year to start January 1st. But I bet some people won't realize that their plan is terminating until the first time they try to use the plan in the new year. Fortunately, these people, if they find in January or February that they no longer have this coverage, they can still enroll in a new plan to start the first of the next month. Now, if you're in a plan that's terminating the end of the year and you have extra help, January 1st, if you don't do anything, you're going to wind up in original Medicare and you will be assigned to one of those two benchmark Part D plans. But I'm worried about the people that are in a terminating plan who do not have extra help, because if they don't choose a new plan for by the end of the year, by default, they'll be on original Medicare, but they'll have no Part D drug coverage at all at the beginning of the year. So I'll just leave you today with some resources. For those that live in New York City, you can call the 212 number. For those that live outside of New York City or know someone that does, but lives within New York State, they can call the 800 number for assistance to be directed to your local county. For those that live outside of New York State or thinking about moving outside of New York State, you have the shiphelp.org website to find a local SHIP counselor. That's the federal name for our program in your state. And then I was mentioning to Senator Krueger earlier that the Department for the Aging is hosting Medicare Advantage plan panel meetings in each of the 5 boroughs. You can see the link here and click on that to see our schedule. Our first one is this Friday in Manhattan at 2 Lafayette Street near City Hall. You can register at that link. And it's especially helpful for people whose plans might be ending the end of the year, where you want to see what's available. And this is a unique opportunity to hear from multiple plans. We have them sit on a panel, and then you can compare benefits and cost and features between the different plans. For those new to Medicare, we offer Introduction to Medicare workshops online. This is the schedule, and you can register at this link. But we also do them in person at the same 2 Lafayette Street location. Our next one is October 17th at 10. And people can contact us directly if they would like to register. So I know that's a lot of information in a short period of time, and I'm glad to answer any questions that you might have.
Thank you so much, Eric. Like you said, it's a lot of information at one time. So I am sure that we won't get through all the questions, but we're going to do our best now. I'll just start to go through questions that we had received prior to today starting. And I just want to, I think some of the questions will be repeats of the answers you already gave. So one was about spreading the deductible over 12 months, and I believe that you did make clear that that is possible for people who paying it all at once can be quite a hefty lift, but spreading it over 12 months is more realistic for them. So that's great. Because everybody's always concerned about the drug costs. If you join a Medicare drug plan and you get a supplement, do you get a reimbursement for the balance not covered by Medicare?
If you join a Medicare drug plan and you get a supplement, a Medigap plan, I assume they mean Medigap when they say that's another name for Medicare supplement plan.
Yep.
Those work completely separately. They work completely separately. So the Medigap plan is designed to supplement Part A and Part B to fill in the cost that you have in original Medicare that I went over at the beginning of the presentation today. But the Part D drug plan is completely separate, and it just covers your drugs, primarily your drugs that you get at the pharmacy.
Got it. Okay. And people are always confused when they're told that they have some share of the medical bill to pay themselves. And so a question is, will Medicare pay 80% of a non-participating physician's bill? Because I know people get confused. It's 80% of full cost. It's 80%
Right.
normal and expected. We don't know what all that means. So
Sure. So let me explain it a little more. So most providers in the United States, most doctors, sign a participation agreement with Medicare. And these doctors always agree to accept what they call assignment on claims, meaning they agree to accept whatever Medicare allows as their full payment. And then the patient is responsible for any unmet portion of the annual deductible, plus the 20% coinsurance, 20% of what Medicare allows. Now, in this question, they're saying non-participating. So I'll assume this is a doctor that did not sign that participation agreement. Those doctors, although they're part of Medicare, they actually have a choice on the patient's claim to accept assignment or not. If they decide not to accept assignment, they can charge not only the annual deductible plus the 20% coinsurance, but up to what they call a limiting charge. The federal limiting charge is 15% above the Medicare allowed amount.
thank you. So in your presentation, there was some data on 2025 costs, but they seem to be the same as 2026 costs. So is that an error, or are there no cost changes between 25 and 26?
So what I did today is, at this point, they have not announced the new Part A and Part B amounts for 2026. Yep. So in my slides, I have the 2025 numbers, plus I have estimates. Those are only estimates of what those costs will be for 2026, and that's taken from the Medicare Trustees Report. But the other numbers, such as the out-of-pocket limit, for Medicare Part D, I do have the 2026 numbers within the presentation. That some of those are very similar to 2025. So, for instance, the Part D out-of-pocket limit this year it's $2,000, next year it's $2,100. Also, the MOOP, the out-of-pocket limit for Medicare Advantage, is also very similar, where this year it could be up to $93.50 in network. Next year, slightly lower, up to $92.50 in network.
Thank you. Okay, so just jumping around a little bit because I think this fits in with what we're talking about. So the drug pricing is always quite a bit confusing. How do you know which Part D plan you should be choosing now when you might not know the pricing until later, and that's too late to change it again? Am I right?
So with Medicare Part D, the best you can do is to go to the Medicare website, and we'll do that for you if you need assistance with that. Okay, Medicare.gov, they have this plan finder search tool where they have the information today for 2026. If you enter the names of your drugs, not just the names, but the dosage, the strength, the quantity you take each month, and then select your pharmacies, you will get a comparison and of all the plans that are available for next year, and they will be ranked based on your needs from least expensive to most expensive. And that's the best comparison you can make for 2026.
Okay. So let's say you're one of those lucky people who doesn't have any prescriptions, and therefore you're thinking, I don't need to sign up for Part D, or I should look for some kind of zero cost plan because I can probably just pay for things myself outside of plan since I don't seem to really use prescriptions. What's the right answer for someone who doesn't think, obviously they don't know what will happen 3 months from now, but they don't think they're actually paying for prescriptions now?
Right. So Medicare Part D is a voluntary program. I can't tell you have to sign up for Part D. That's not true. But if you don't sign up when you're first eligible and you don't have other what they call creditable drug coverage from another source, such as some people have from a former employer or union, such as veterans may have through the VA, and you decide to sign up for Part D later, you may be subject to a late enrollment penalty. But what I think is even more important than the late enrollment penalty is the fact that you can't just sign up for most people, sign up for Part D whenever you want. So if you don't use any drugs now, but 5, 10, 15 years from now, you get sick in the middle of the year and you need some expensive medication, you can't sign up for Part D for that reason. You may have to wait till the next year. So what some people will do is they will just, who don't use any drugs, they'll just choose the lowest cost plan possible to have something in place should their situation change. If you're in a Medicare Advantage plan, you could find Advantage plans, including Part D, for as low as 0 premium. If you're in Original Medicare, I mentioned earlier that next year, the cheapest plan will be from Cigna, HealthSpring, as opposed to this year where it's from WellCare, in case you're just following the lowest cost plan and you're in Original Medicare.
Great. So I think we all have a basic understanding of in-network and out-of-network coverage for different doctors and even hospitals. Do Medicare Advantage plans specifically allow patient visits with out-of-network doctors?
So it depends on the Advantage plan. So first of all, with the Medicare Advantage plan, if it's an HMO plan, that's the most restrictive type of plan. Because with an HMO plan, unless it's an emergency, you're limited to doctors and hospitals that participate, that accept the plan. If you go outside the network, you're going to wind up paying the cost out of pocket. To some HMO plans, though, offer a point of service option. You see this abbreviated HMO-POS. They allow you to go out of network, but you really got to look at the details. It's a limited out-of-network coverage. So for instance, they don't necessarily cover all types of services out of network. But the PPO plans, Preferred Provider Organization plans, give you a little more flexibility. Because with the PPO plan, they also have a network, but with the PPO plan, you could also use out-of-network providers so long as they're in the Medicare program. And again, you might have to pay more out of pocket when you do. You might even have to pay up front and submit your own claim if the doctor's not willing to do so. But for that reason, the PPO, again, gives you more choice, more flexibility than does the stricter HMO plan.
Got it. And we know that over the last couple of years, it seems that Medicare has been expanding to cover things like hearing devices and some dental coverage. Is that, if you're looking for hearing, dental, are you better off for some reason with an Advantage plan than traditional Medicare? I know when you watch those TV commercials, which I think are designed to mostly confuse you, the Advantage plans are always talking about they offer this and regular Medicare doesn't. So I think we can get confused here.
Well, I would say that's true. That original traditional Medicare does not cover things like dental, does not cover eyeglasses, it does not cover a hearing aid. So when the Medicare Advantage plan says they provide those additional benefits, they are actually additional benefits. But I would say you would want to look at the limitations of those additional benefits. So for instance, many Medicare Advantage plans provide both routine dental and comprehensive dental, where they cover for procedures. But usually it's only up to a set dollar amount for the year, $1,500, $2,000 to $2,500. So it's for most, if not every plan, it's not an unlimited benefit for dental. But whatever they're providing, it's more than what Medicare is providing, because Medicare just doesn't cover these dental procedures. Okay? There are always some exceptions where Medicare has to cover a dental procedure when it's an integral part of a medical procedure, and that you may have seen where they clarified the rules for that within the last year or two. But for the most part, dental is just not covered under original Medicare, and many, if not most, of the Advantage plans provide additional dental coverage, but with some limitations. And the same thing for the hearing, too. If you need a hearing aid, most plans give you a set dollar amount for a hearing aid. $1,000, $1,500, $2,000, that could be applied every year, every 2 years, every 3 years. So they're not actually covering your hearing aid, but they are just giving you money towards that. But again, whatever they give you, it's more than what Medicare is providing, which is nothing for a hearing aid.
So I'm not on Medicare because I'm employed. And so in my health insurance, if their maximums that I have to pay out of pocket before insurance kicks in, right? Deductibles. So, but in Medicare, it seems, at least if you're taking drug coverage, if there are products where you have to self-pay, why doesn't that cost apply to your 2,000 maximum for the year?
Yeah. So if the drugs are not covered by your Part D plan, then those costs will not apply to your Part D deductible, which next year could be up to $615, and will not apply to the maximum out-of-pocket limit, $2,100 next year. Those are for covered drugs, okay, where only the covered drugs under your plan would be applied towards these amounts.
And are there any tricks for us to know about ways to recover out-of-pocket costs on drugs that don't seem to be covered under our drug plan?
Yeah, so if you're in a Medicare Part D plan, sometimes people run into the issue where the plan doesn't cover their medication. So if your plan does not cover your medication, they are required to cover other medications for the same condition. So every plan has drugs they cover for high cholesterol and for diabetes and for depression, but it's not every drug. So if your doctor's prescribing something that the plan doesn't cover, the first thing I would suggest is talk to your doctor to say, you know, they don't cover this drug, but they cover these other three. Is one of the other three the equivalent? Can you prescribe that instead? If the doctor can, problem solved, plan pays for it. If the doctor cannot, though, if the doctor says, no, we tried this, you had a bad reaction, just not as effective in my professional opinion, with the doctor's help, you can request an appeal, an exception, where if the doctor can prove to the plan that that's the one drug you need, the plan would need to cover it at least through the end of the year, at which point you could always switch to another plan the following year. And I'll just, again, mention the EPIC, right? Because for people that have EPIC, and again, if you don't, you can join at any time of the year. If you have EPIC, now you have some additional flexibility where you can change your plan, Part D plan, including a Medicare Advantage plan with Part D, in or out. So if your needs change during the year and you find there's a better plan, okay, you don't have to wait. If you have EPIC, you can sign up for that plan once a year and be in a new plan the first of the next month.
Got it. That's important. Thank you.
Yeah.
So sometimes doctors are prescribing drugs that the drugs aren't officially approved for X treatment, but they are officially approved for Y treatment. But sometimes it turns out these drugs that are only approved for a certain set of illnesses prove to be really effective on other kinds of illnesses. Does Medicare cover those drugs? Do they care whether it's approved for X when you're actually going to use it for Y?
Yeah, so you should not expect that the Part D plan would cover your drug for non-FDA approved use. Okay, they wouldn't be required to do that. Again, you could do the appeal if they're not going to approve that, and you could go through that, with them. But they're not required to cover drugs for non-FDA approved purpose.
And it's not really a fair question, but it doesn't necessarily feel like FDA is functioning normally right now, or might actually be approving additional drugs. is there anything we need to think about in relationship to the choices we need to make in Medicare in the context of just not being sure if the FDA is going to continue to play the role they've been playing?
Well, people can only make a comparison, I would say, of based on their needs right now, right? Because that's all they can do. And then see, based on the drugs they're taking now, what would be the most effective plan for them for next year. Bearing in mind that should something happen and they develop a new condition or need a new medication, again, the plans, whatever plan they're in, they cover, if not that drug, other drugs for the same condition. And if you can't use the other drugs, again, with the doctor's help, you can request an appeal, an exception. So I think people should base their choices on the information that's available now, but they should also be aware of these protections they have should their situation change and opportunities they have to switch plans.
Right. Okay, so this is an issue we definitely get here in Manhattan. You're looking for a healthcare provider who accepts Medicare. And you're trying to figure out whether your provider, either that you're using now or you're looking to choose, actually is accepting Medicare. Because sometimes when you go online and look at these lists and these in-network lists, they're not so up to date or even correct. So what's your best recommendation for how we go about finding, we've already decided on what our plan is going to be, and now we want to find doctors and other healthcare providers who actually accept the insurance that we have chosen. What's your best recommendation?
Well, if you're on original Medicare, what I would recommend is going to the Medicare.gov website, and you could search for providers that are in the Medicare program by zip code and by specialty type. If you're in a Medicare Advantage plan, okay, then you may need to check with the plan to make sure that your provider is in network. You can go to the plan's website and see their provider directory, but like you're suggesting, it may not always be up to date. And you may want to call the plan to confirm that that doctor is still participating in the plan.
Yep, I definitely recommend that because we hear that story not infrequently in my office. That
Okay.
you think your doctor's in a plan or that he's in network, and you go to them and then you learn afterwards, no, he's in one version of a plan, but not the version you're in, which is really confusing. Or he's no longer in, even though he was at one time. Those stories are not infrequent.
Right, because the same insurance company, United Healthcare or Aetna, they have multiple different types of insurance.
Right.
And
Exactly.
the doctor may be participating in one or more of their plans, but not in others. So they might tell you they accept Aetna or they accept the United Healthcare plan, but what I would ask them is, do you participate in the Medicare Advantage plan from Aetna, from United Healthcare? Okay, so they can more limit the focus.
So do any of these rules change in Medicare if you're living in a different state or even in a different country?
Well, original traditional Medicare provides the same coverage throughout the United States and its territories. So if you're in original Medicare, you have the same coverage if you're in Florida half the year or Arizona as you have here in New York. If you're in a Medicare Advantage plan, okay, especially if it's an HMO plan, unless it's an emergency, you're limited to a network of providers. Some plans have participating providers in other states. Others are limited to this region of the country. As far as outside of the United States and its territories, Medicare itself provides no coverage at all for services outside of the United States and its territories. Some people that are in original Medicare that have a supplement, a Medigap plan, most of them cover foreign travel emergency services as an additional benefit. But again, original Medicare does not. If you're in a Medicare Advantage plan, most Medicare Advantage plans have limited coverage for emergency services outside of the United States. So that's something you would have to confirm with the individual Medicare Advantage plan, the details.
Okay, so this may be a better question for our next roundtable, which overlaps changes in Medicare and Medicaid. But let's say you're in Medicaid or the essential plan, and you're turning 65, which will mean switching to Medicare and then paying premiums, deductibles, etc., which you're not paying now. Are there any things you might be able to do to help decrease the cost when you're transitioning from Medicaid or essential plan to Medicare?
Well, very different for Medicaid and essential plan to Medicare. So let me talk about Medicaid first. For people, we speak to a lot of people that have Medicaid through the marketplace. Now they're becoming Medicare eligible due to age or disability. The most important thing they do is enroll in Medicare, Part A and Part B. If they're collecting Social Security, it'll be automatic, but if not, they should enroll. Automatically, because they have Medicaid, when they're becoming Medicare eligible, they will get extra help with Part D. They don't need to apply for it. They will get that automatically. And they will be assigned to a plan with Medicare. But people should, rather than wait to be assigned, actively choose a plan, okay, to make sure that it meets their needs. But if they do nothing, they will be assigned to a plan. Now, let's talk about the Medicare Savings Program. People with Medicaid in New York State, people with Medicaid that become Medicare eligible and enroll in A and B automatically get the Medicare Savings Program, the QMB program. However, it does not start the first month you have Medicare. It starts automatically the second month you have Medicare. So people that have Medicaid that become Medicare eligible, again, that enroll in A and B, they will be responsible for the first month of premium. Okay, after that, the state automatically will pay the premium for them. Completely different for people that have the essential plan. Okay, people that have the essential plan, which for those that don't know, that's for people in the marketplace whose income might be a little bit above the Medicaid limit. The essential plan is not Medicaid. And for these people, when they become Medicare eligible, they do not get extra help automatically. They do not. They do not get the Medicare Savings Program automatically. If they are eligible for those benefits, they need to apply for them, or else they will not have those benefits.
You know, it is so confusing. I wonder why people are calling your phone number day and night just to try to figure out the right decisions for themselves. And so that if you are moving to another state mid-year, I'm guessing that A, B, and D are portable, but let's say you're in a Medicare Advantage plan and you've signed up for it, I think, for a year, and now you're moving to another state that might not even have that Medicare Advantage plan. What are your options?
Right. So if you're in a Medicare Advantage plan and you move to another state, or even within New York State to another county, you're entitled to a special enrollment period, where even if your plan is still available there, it might or might not be, you'll have an opportunity to sign up for a different plan that's available in that county, okay, based on your move. Okay, so you're protected in that way. Okay, if you're on original Medicare and you have a Medigap plan, right, then you could just take the Medigap plan with you when you move to another state. Okay? The Part D plan, you know, that if you're in original Medicare, it might still be available in the other state where you're moving to. If not, again, like the Advantage plan, you have a special enrollment period to switch.
Got it. Okay. And just if I get this right, if I keep my Advantage plan for next year, can I switch back to traditional Medicare at any specific time, or do I have to wait to a new open enrollment period for myself?
If you have an Advantage plan at the beginning of next year, You can use the Medicare Advantage open enrollment period, January to March, where you can switch one time into either another Advantage plan or to original traditional Medicare to be effective the first of the next month. We mentioned earlier that if you also have the EPIC program, you can make one additional change each year, including into or out of an Advantage plan outside of this enrollment period.
Got it. And there was some question you answered talking about benchmarking. What does benchmarking mean when you're looking at?
Sure. So that's this is for people that have extra help, that are in original traditional Medicare. This year they have 12 Part D plans. Of the 12, there are 3 of them that are the benchmark plans. And that means the subsidy that people get with extra help is enough to pay the entire Part D plan premium for them. So if the people with extra help that are in original Medicare are in one of those 3 plans, they pay 0 premium. If they're in one of the other 9, they may pay a premium above the subsidy amount. For next year, one of those plans is going up substantially. The plan from SilverScript, the Aetna SilverScript plan, where it's going up $50 a month in premium next year, and it will no longer be a benchmark plan. And if people with extra help have that plan, let's say people with Medicare and Medicaid that have extra help have that plan, unless they move to one of the 2 remaining benchmark plans for next year, they're going to wind up with a bill for the premium above the subsidy amount, which next year for that plan is going to be $57 and change per month versus 0 currently. Big difference.
Right. Okay, so as a state legislator, I know that we passed some laws, actually 2 different times. One, that if you are taken to a hospital in an emergency and taken into the ER, then even if that hospital isn't covered as in-network for your insurance plan, that you can only be charged whatever it would be if you were in that insurance plan and in-network. And then later on, we expanded that to you're taken into an emergency room, they can only charge you as if you're in-network, but then you have to be sent upstairs for surgery because of the emergency. And that wasn't being treated the same way. So then we passed law to treat that the same way. Does that apply to Medicare and Medicare Advantage? I can't remember.
So state laws, apply to other insurance, right? Medicare is guided by federal regulations.
Right.
So original traditional Medicare, you wouldn't have that situation, right? Because the providers would be reimbursed. They're all in network, if you will, right? Especially in the hospital setting,
right?
With the Medicare Advantage plans, they have to, even if it's out of network, they have to cover you for emergency care, right? In an out of network, if that's the nearest facility, they have to cover you in an emergency to use that facility and those providers that are affiliated with that, until your condition could be stabilized. So you should have the in-network cost sharing in the end.
Right. Okay, that's important. Thank you. Well, all these questions are important. But actually, I can't believe I'm going to say this. I think we've gone through all of the questions that we got in advance, and I'm just looking to see if there's any more I didn't get to in the chat that my staff's been sending. Oh, here's a new one that came in, I guess, right now. Doctors are now requiring patients to pay a concierge fee. And would that be legal if you're in a Medicare plan?
This is for people that are in original traditional Medicare.
Yeah.
So some doctors have opted out of the Medicare program, especially in Manhattan, right?
Right.
And those providers, they can charge whatever they want. Medicare reimburses no part of their costs. They're not in the Medicare program. But there are some doctors who wish to remain in the Medicare program, but they, because of the limits Medicare places on what they could charge for services that Medicare covers as a way to get additional revenue. They charge a concierge fee where they charge you a certain amount per month or per annually, $500, $2,000 or more dollars, where that allows you access to the provider. Okay? It is not for medical care though, because if it's for medical care, these doctors that are in Medicare, they can't charge $2,000 for an office visit. Medicare limits them to what they can charge. So the way around that is the concierge fee, where they are charging not for medical services. They are charging, if you will, a membership fee just to be part of their practice and to have access to the doctor, okay, for questions or something like that. Okay, you see that sometimes with providers that are in original traditional Medicare. And that's not a problem for Medicare. They're able to charge it again because it's not for medical care. Okay, if you're charging and it's not for medical care, so it's not limited by Medicare.
Wow. All right. See, I never would have guessed that. So that's excellent for people to know about. Oh, I'm sorry. Since we were talking before about people who might choose not to join Medicare at certain dates and times, for example, someone who was using VA benefits. And now we're hearing, and you could have been using VA benefits already for 20, 30 years, right? We have great VA hospitals here in Manhattan, for example, we have a great one. And then it sounds like the feds are planning on changing some of the rules about VA coverage. When you decide, oh, I need to go into either traditional Medicare or Advantage, are you going to be treated like someone who failed to do it when they were supposed to and get hit with an enormous penalty? Or will there be some recognition that you had a benefit that may not even exist the same way in this country anymore?
Well, there are differences as far as, and this is not something new in Medicare, but there are differences with the VA coverage when we're talking about Part B medical insurance and Part D drug coverage. So let me talk about Part B medical insurance. If you have coverage through the VA and you get all your medical care through the VA, some veterans don't want to sign up for Part B and pay an additional premium, but
Right.
they're taking a chance, because if they're going to need something care outside of the VA system in the future, they're going to need to wait to enroll in Medicare, the next general enrollment period, January through March, and they will be subject to a late enrollment penalty. They will, because only people that are covered through active employment can delay Part B without penalty. Part D, though, is different. So the Part D drug coverage, veterans, their drug coverage through the VA is considered creditable drug coverage, as good or better than Part D. So veterans that don't sign up for Part D, if they sign up later, would not be subject to a penalty. Okay, so very different for the veterans, Part B versus Part D. And again, that's not something that's changed in Medicare.
Right.
That's
right.
It's been that way.
All right, now it is officially time for me to thank you profusely for again proving that you can't stump Eric with Medicare questionnaires, Medicare questions. And you should, again, you have their phone number. HIICAP is an amazing service that I'm so appreciative of on behalf of everyone in the city. And again, you're going to get emails from us with information. If you would also fill out the survey, that's very helpful. I think also particularly for Eric, so that people who are dealing with HIICAP recognize how important the work he is doing for all of us is. I want to remind you that we will hold our next roundtable on the impact of federal cuts to Medicare and Medicaid next Tuesday, October 14th, same time, 2 o'clock. And the link for that town hall will be listed in the chat, or maybe it is already. And if you're concerned about federal cuts to Medicare and other vital services and resources, or the health of our democracy, you might want to attend the No Kings event, a National Day of Action, Saturday, October 8th, at Father Duffy Square on 47th and 7th from 11 to 1. I think there are millions of Americans planning to attend over 2,000 events in the country that day. And also, let's not forget, there are upcoming New York City elections. Early voting will be starting October 25th through November 2nd. Election day is Tuesday, November 4th. And for information about early voting, mail-in voting, televised debates, consult with nycvotes.org or call 1-866-VOTE-NYC to get more information about participating in our democracy. And finally, please remember, get the vaccines that you are eligible for or have been advised by your doctors to get. Certainly at this point of year, we're talking about COVID. There's a new COVID vaccine, flu vaccines. This is the time of year, particularly for those of us who are older, may have respiratory illnesses or other kinds of chronic illness, to make sure that they talk to their healthcare providers and get all the vaccines that can be very, very helpful to them. I know I've been going through a checklist for myself of like every vaccine anybody of my age should be getting. And there's a lot more than you realize, including a few vaccines that you really should get every 10 years, but I hadn't realized. So I'm a big believer in science and medicine, and the folks who do the science and medicine are not changing their position about why vaccines are so important to us all. So with that, Eric, thank you so much. All of my staff, without whom I could never get this done, thank you. And for those of you who stuck it out with us, I hope you found valuable things. Oh my, as we're saying goodbye, 12 additional people decided to fill in questions. My staff will try to respond if they can, but I can't keep us on the web any longer. Thank you very much. Take care.